Hello guys, today we're gonna be doing the palpation part of the ulcer, right? So we completed the history part, we completed the inspection part. So we're gonna be, you know, using our hands now and getting it dirty into it, right? So for the tenderness, we saw, right, we have to see the pain history, right? So here we're gonna be seeing the tenderness of that. And pain was the history part, the patient told, and now we're gonna elicit it. So even if it's mildly painful, the patient doesn't normally, notice it. But if we press onto it, he will scream in pain, right? So an acutely inflamed ulcer is always tender. We all know that, right? Where anything acute is usually very painful, right? So, but the chronic ulcer, what would be the chronic ulcers? Like associated secondary ulcers, right? The tuberculous or the syphilitic are slightly tendered, right? But this varicose ulcer, it's very, it varies. It literally varies, right? It could be tender or it could not be tender. It's very, मन का अपना मौला है वो, ठीक है. फिर the next thing would be the neoplastic ulcer. These are never tender because it's just gonna wreak so much havoc already, right? It doesn't need to give pain also, so we can learn it like that. The next thing would be the edge and the margin. We already saw in the inspection part, right? The edge and the margin. So what are we going to do, again with it, right? But here we're gonna palpate the same thing and we're gonna confirm, like, right, what our eyes saw, we must confirm with the palpation. That is all what the surgery is about, really, right? So for the margin, I told you what's margin. It's a junction, right? I told you if this is the ulcer, then this would be the margin, this would be the margin, right? That you see from above, right? Or it's the junction between the normal and the abnormal thing. This is the normal thing, this is the abnormal, this is the junction, right? This would be the margin, this would be the margin. And the next would be, so it's, you can usually call it as a boundary of the ulcer. It's literally boundary. And the edge would be this edge, we already saw that. And this would be the floor, we already saw that. So what we're saying is, why do we need to label all this? Because the activity is maximum at the margin and the edge, right? Here is the name of the game of this ulcer, right? It's the main thing. This is already conquered, but this is the army that the ulcer is sending to conquer the normal areas, right? So the next would be the palpation. I already told you, you need to corroborate it, yeah, right, with inspection findings and see if what your eyes saw were the real thing or not. And obviously we're gonna be palpating, so we're gonna see what we're gonna touch. Actually, we're gonna feel whatever it's there, right? So marked induration or the hardness in the base of the ulcer. This was the base, right? We're gonna palpate it, and where it's marked induration means it's very, very hard, right? So it would be the squamous cell carcinoma. It's a carcinoma, right? It needs, a hard base to grow upon. And it could be adenocarcinoma. We already saw that, ulcerating adenocarcinoma, right? And in chronic ulcer, some induration might be there because it's so chronic, right? The body is like, I need to have a strong base to handle this swarm of long assault, right? So the other thing would be this base. We were already seeing it, but if in particular, if we see what it is, it's where the ulcer rests, right? It's better felt than seen. It's very, very important VABA point that is usually asked. And we already saw induration in squamous cell, right? And in the long term, right, Hunterian or TB ulcers. And the depth, it's not that important, but obviously in trophic ulcer, I told you, it's gonna go so deep into it, right? It's gonna reach the bone. So in millimeters, you normally you just assess it. You can't literally make a record of it in the examination, but in palpation obviously you can. So if we can see the other signs associated with it also, like the bleeding, if it bleeds to touch or not, right? We saw the serosanguinous discharge, and if it's normally bleeding to touch, it's not very good because it's gonna be malignant, right? So and other deeper structure, what are the relations of it, right? So what do you mean by relations? Like, what is happening to the deeper structure? Ulcer is there, no worries, but what's gonna happen deeply? So if the ulcer is made to move over the deeper structure, we get to know if it's fixed or not. And it's very important to know the fixation. We all know where the ulcer, or the lymph nodes, they get fixed. Why? Because like in gummatous ulcer, it is over a subcutaneous bone, like we saw in tibia or sternum, right? So obviously it's gonna be fixed to it. It's so superficial that it gets fixed anyway. But in the malignant ulcer, is so invasive that it's gonna be fixed anyway, right? So in the surrounding skin, like we also, if there is erythema, if there is eczema, there is pigmentation, whatever, right? So we can see the temperature part, the tenderness part. If it's of an infective origin, then these could be there. And like in the acute inflammatory origin, right? Infective or inflammatory, right? It need not be infective per se, but like inflammatory, right? All the IL-1, IL-6, all these inflammatory cytokines will make these a sure thing. And fixity, we already saw. Malignant ulcer, no need. And we can see what is the condition of the skin. Is the sensation there, or the motor deficit is there, right? Because we saw, like in the trophic ulcer, this is the problem. And right, wait 1 second. Yeah. And try to feel the peripheral nerves, right? Why are we concerned with the nerves? We saw the sensation. Why the nerves though? Because nerves could be thickened, and there could be tenderness, right? In the leprosy part, there is a thickening of the nerve, so we can know if the sensation loss is associated with that, and whether the ulcer is happening because of that, right? So and other things, we could be seeing the arteries, right? So arteries, what are the arteries? Why the arteries problematic? It could be atherosclerotic, right? Because there is plaque formation, and there is narrowing of the arteries, so like blood is not going there. Or there could be Berger's disease, right? What is Berger's disease? It is a Berger disease that is also called as thromboangiitis obliterans, right? There's a thrombo in the angio, and it is obliterating something, right? TAO, right? It is obviously a peripheral vascular disease, and it is usually associated with smoking. So you can, if you want to learn this, you can just see, like, whenever we are doing the, bad things, eating unhealthy food and all those things, and the other smoking habits can be associated with it. So you learn with the Berger. Another thing is Berger. That is different, right? Berger's disease is usually IgA, right? This is different, but this is burger, right? BUR, right? Anyway, and then another would be the Raynaud's disease. What is Raynaud's disease? It's usually associated with the CREST syndrome. CREST is, there is a thing called systemic sclerosis, and then when it's not systemic, it could be localized, right? CREST syndrome, right? So in that, the R thing, CREST syndrome, the R is for the Raynaud's. What happens is, usually there is a history of exposure to the vibration or anything like that, right? And there is a skin change because of that insult or stimuli, right? So this is the sequence Weber, like rubber, Weber, anyway, right? So Weber is, what is Weber? White, blue, and then red. So it usually becomes pale first, right? The blood supply goes away, then becomes blue. Why? Cyanosis. But whenever the blood supply comes back, it is R, right? So this is called Raynaud disease, and we have to see because it is associated with the arterial problem. And this was arterial, right? And we can see the venous problem also. So venous ulcer, we can see what is happening there, varicose vein or something like that, right? So yeah. And the next would be the examination of the lymph node. So this is the stigmata of syphilis, and I'm going to be teaching this in a separate video, but it's associated here only, right? So Estas gave it here, but it's beautiful to learn about the syphilis, and I've included all of this. I will teach it in a later video. So first things first, we have completed our examination of the ulcer, our examination, right? The inspection, the palpation, but we're gonna be doing the lymph nodes now because they're heavily associated with this. So in the acute, what happens to the lymph nodes? They are enlarged, tender, whatever, right? Later they become softer, or they form an abscess, right? Whatever. And in the TB ulcer, we saw that all the lymph nodes, they're going to be like, they're going to be enlarged. And this is very important, the TB are matted, right? They're exactly like kind of a firm consistency. These are matted lymph nodes, and slightly tender. We also, right, it could be slightly tender. But this Hunterian cancer, what was that? This was primary syphilis, right? The lymph nodes remain discrete, firm, and shorty. What is shorty exactly, right? You can learn it like that. Hunters shoot, right? So what is shorty? Short is literally like, pellet, like very the pellet of, for the bullets, right? They feel like that. So small round bullets, right? So discrete, firm, and shorty. But the matted kind of firm thing, these are TB lymph nodes, right? So this type of, obviously, it's pathognomic, right? It's so different than the others. And in the gummatous ulcer, it's not usually involved. So that is very important thing. When the disease, the syphilis is disseminated, this is systemic, right? Tertiary syphilis, then the lymph nodes are not that much involved. But in the primary stage, the lymph nodes are involved heavily. And in the rodent ulcer, obviously, it's like non-invasive, right? It just stays in its place. It doesn't even metastasize, right? So no lymph node involvement. And why is it that though? There is early obliteration of the lymphatics. Like literally, the cute mouse we saw, it gnawed away at, the lymphatic also. So there's obliteration by the neoplastic cell. So, it's not gonna transport here and there. And the malignant ulcer, we all know, like it's all stony, hard, and fixed, right? Fixed to the structures, surrounding structures. And stony hard, so hard, right? It's very hard to miss, literally, right? And yeah, so that would be the lymph nodes. And we can see the vascular insufficiency for the ulcer in the lower part, like the varicose in the upper part, right? And we can see if there are no varicose, or what are the, arteries condition. We can palpate all the peripheral arteries, and we all know the surface marking of different arteries, right? So we can see all these conditions that we saw above, Berger's and, atherosclerosis, whatever, right? um you know yeah. So I told you one thing before, right? The ulcer situated on the lower part, one should always search for varicose in the upper part of the leg. I told you, right? If there is a blood circulation problem, and if here is the ulcer, then you see here what's the problem, right? Because the blood supply was coming here or going from there, and that's why the ulcer has occurred here. So for the examination of nerve lesion, we already saw, right? For the trophic ulcer, we see the repeated, trauma, insensitive part or whatever, right? So, all these things I already explained in the previous video. You can check that out. Davis dorsalis, transverse myelitis, peripheral neuritis, all these very easy things. And yeah, we already did the, local examination. Now we can do the general examination, right? For the syphilis, we can do stigmas. What are the stigmas? These are the stigmas I'm going to be teaching in the next video. And for the tuberculosis lymph nodes, again, Berger's, which is a bilateral. This is important point, right? We saw that Berger's smoking, right? It's a bilateral because obviously it's like systemic thing, right? That's why it's just bilateral thing. And trophic, we can see like which type, right? All these things, whatever it is, right? So I think I should cover this. It's not very hard, the special investigation. And in the next video, I'll be talking about the classification and the differential diagnosis of the ulcers. So for the special investigation, you can see the routine examination of the blood, right? Because we have the diabetes mellitus association, we have the right, syphilis association. So this is the Wassermann and Kahn test, right? These are the antibody complement fixation, right? Whatever antibody is there against the syphilitic, like treponema pallidum, right? These are the tests that are gonna check, right? Tuberculosis, you can see the lymphocyte count, like we all see the tuberculosis CSF meningitis, right? So lymphocytic, heavily lymphocytic, right? So ESR, the erythrocyte sedimentation rate is usually acute phase reactant, right? So it's gonna be there, and there might be anemia, like this is very usual that we already do anyway. And CBC, blood sugar, whatever. And you can do the examination of urine also, because obviously you can see the sugar there, right? And we all saw, right? You can take the swab, right? So what are you going to do with the swab? You can see the type of organism, you can see, sensitivity to the antibiotic, so you can give very very targeted treatment, because nowadays the resistance is so much against so many of the beautiful antibiotics that saved our lives, that have increased so much of our um, life expectancy, but then we are getting resistant to it, and it's very scary situation. So it's better to do a sensitivity testing. And you can see the dark ground illumination, right? What is this dark ground illumination? Let me see. So it is for this treponema, right? So what is treponema? Treponema pallidum is the organism that causes the syphilis, right? So it's a spirochete. Spirochete, why? It's very spiral. It's literally spiral, right? And spiral and very small, right? So with the normal stains and with the normal light microscopy and stains, we can't see it. So what we do is, these are the actual spirochetes, and this is the dark background. So this is dark ground illumination. We literally illuminate these buggers, right? And we are just left with the dark void behind. So what we do is, you can see, if you want to just see the mechanism of this, this is the unique thing that we do. We put a opaque disc here. Normally these lights also go, these also go, right? This is usually what happens in a microscope, right? So everything will be going to your eye, right? But here we are blocking this. If we block this, then this condenser won't have these lines, right? So for the specimen, these lines won't be there, and in the objective lens and the ocular lens, these won't focus again, right? So the middle part of it is not there. That's why just these small things, these are illuminated, but in general the background is dark, right? So what we can do else than this? The chancer is first cleaned with saline, and the serous discharge from the chancer is taken with the platinum loop, right? So what the chancer is, it's the hard chancer for the syphilis again, right? And for the TB also, what is TB? TB is the very like acid fast bacilli, right? What is acid fast? Is a Zeal Nielsen stain, Zn staining, right? These are its components. The CAM, right? What is this? This is carbolfuchsin. This is the primary dye, and then we put the acid, right? It's gonna fix it, and then we can use the methylene blue, that is the counter stain, right? So bacteria, primary stain is the bacteria, right? And the counter stain is the background. So it will be literally pink over blue, right? So that is the acid fast bacteria, and tuberculosis is like the main acid fast bacteria. And the skin test, you can do Monto test. What is Monto test? This is for the tuberculosis only, the same thing. The tuberculin, PPD thing, right? It's injected, right? Tuberculin is injected, and we can check for the wheal, right? Wheal formation. Wheal is the literally the reaction to this whatever we have injected into the arm, right? And if the wheal is positive, then the test is positive, like there is history of TB there, or it could be history of vaccination also, but this is one of the tests to determine exposure to TB basically. And the chest x-ray, we can see for the tuberculosis, if it's pulmonary, right? The primary focus, Ghon's focus it's called, right? And you can see the metastatic deposits also. We saw squamous cell carcinoma or something like that, maybe they have metastasis in the lung there, right? So in the biopsy, this is very important obviously in cases of malignancy, right? The malignant ulcer, we generally take from edge. This is important again, like the edge is taken, right? So that we have some of the healthy tissue and some of the malignant tissue, and we can DD these things like adeno versus squamous versus basal cell. Then x-ray of the bone and joint, right? So yeah, so this was left, right? The syphilis part, we're going to be dealing with it again, but for here we can see there's a thing called saber tibia. The saber tibia is literally bending of the tibia in the this syphilis, right? And then the contrast radiography for the arteriography. Whatever arterial problem is there, we can do arteriography, angiography, right? Whatever is the problem. Normally in the deep vein thrombosis, we can usually see it with the help of Doppler, right? And we can see the change in the phase form of the flow, right? Normally the veins are monophasic, right? And it will change in this, right? And the imaging techniques, whatever, these are like very rare things. We are not usually taught this, but you can do the radioactive fibrinogen testing using I-125 labeled, right? Fibrinogen, right? And in detecting the DBT, right? Usually, uh, I've not read this commonly, but here it's written, so I'm just gonna be telling about it. And the technetium also, it's called scintigraphy, right? You can do for this blood flow of the calf muscle, right? So for today, I think that is enough, and then we can do the classification and the differential diagnosis. And for the next, a very small video, I'll be making this so people can look at this without looking at the ulcer per se. Thank you and have a nice day. Bye bye. Meet you soon.